The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
Why does COVID-19 cause as many as 1 in 10 to endure symptoms for weeks and months beyond the active infection? Tonight, 3 top Ontario researchers explain what they've learned about so-called long COVID. Also, we'll examine new data showing that male and female doctors in this province still don't have wage or power equity. It's Monday, January 31st, and thankfully, now back in our studio, that's what's ahead on the agenda. Last fall, Ontario's COVID-19 Science Advisory Table estimated that 57,000 to 78,000 people experienced what's called long COVID. That was, as they put it, a conservative estimate. Now, with tens of thousands of new infections in this Omicron wave, presumably that number will rise substantially. With us on the significance of that for patients and the healthcare system, we welcome, at the McMaster University Medical Centre in Hamilton, Ontario, Dr. Konstantinos Chelios, Assistant Professor in the Division of Rheumatology at McMaster University's Department of Medicine. And in Ontario's capital city, Dr. Anna Banerjee, Associate Professor of Pediatrics and Infectious Disease at U of T's Dalla Lana School of Public Health, and Dr. Angela Chung, Senior Scientist at the Toronto General Hospital Research Institute and Professor of Medicine at the University of Toronto. And we thank the 3 of you off the top here for joining us tonight on TVO for a discussion about something that is too prevalent in our society right now and we need to know more about. But Dr. Chelios, let me just start with you. I don't want to assume everybody knows what long COVID is. So let's start there. What is it?
Thank you so much for having me, Mr. Paikin. I think it's widely acceptable now that we need to follow the World Health Organization definition for long COVID. And they define this, or better to say, post-COVID-19 condition as the persistence of symptoms after an initial infection with COVID-19 that persists beyond 12 weeks, actually, and they last for at least 2 months. These symptoms are mainly fatigue. These patients report that they feel tired all the time. They can be brain fog or mild cognitive impairment, some memory issues. They can be difficulty breathing, particularly on exertion. They can't tolerate exercise so much, and plenty of other symptoms. They have reported at least 200 symptoms up to now to different ethnic populations.
Dr. Chung, let me get you to pick up the story. In the year since you were last with us, what do you know now about long haulers, as they're called, that you didn't know a year ago?
We are learning a lot in terms of what is causing these long haul symptoms. We have some top hypotheses for why people are having these symptoms. Probably the top one is vascular endothelial dysfunction, which means there's a damage to the lining of the blood vessels, and it affects how blood is delivered to various systems. And the second hypothesis is immune dysregulation. So there's a change in the way that our immune system is working, and it may not behaving in the usual way. And then the last hypothesis is really around residual viral particles or residual virus hiding. And those 3 are the top hypotheses right now.
Okay.
And there are studies supporting all of these hypotheses.
And let me get you to follow up on that in this regard. Of the total universe of people that get COVID-19 at all, what percentage of them are long haulers?
You know, it's very difficult to estimate, but I think it's between 10 and 50%. So the lower estimate is 10%, which means, you know, like in Canada, we have more than 3 million people who have had COVID. And so 10% would be 300,000 people. And it may be as high as even close to 1 million. The problem is the definition of long COVID. Do you count people who only have one symptom, like loss of smell and taste, and they're not quite back to normal? Or do you only count those who can't go to work and still have debilitating symptoms and can't do the activities of daily living? And so I think, it's the severity of it that makes a difference in terms of the percentage.
And Dr. Banerjee, let me try this with you. Just as with regular COVID-19, if you're a young person, a teenager, the impact of getting COVID-19 is likely to be a lot less than if you're an older person. Is it the same with long COVID?
So we don't really know how many kids have had COVID to begin with. So we don't have a denominator because kids with mild symptoms don't get screened, and sometimes the test can be falsely negative. And again, we have different definitions of what is long COVID. But if you look at the studies, again, it's between 2 and 50% of kids that have a positive test for COVID that end up having long symptoms. So there's we think in general most kids don't get too sick, but there's a small percentage of kids that have debilitating ongoing symptoms.
And I'll follow up with you with this. Would the symptoms, if you're a younger person and you're a long hauler, be the same as if you're an adult?
I think that there are less kids that have symptoms, but the symptoms are similar with the brain fog, the muscle ache, the shortness of breath, but also it depends on, like for adults, they have more comorbidities. They have higher rates of diabetes and things like that. So there may be more impact, but I've seen children, more teenagers than younger kids, that have quite debilitating symptoms, similar to adults.
Dr. Chelios, what's the longest amount of time you've heard of somebody living with long COVID?
I've seen patients actually with symptoms persisting more than 15 to 16 months. I don't know about 2 years, most likely. We had the first cases in Canada, if I'm not mistaken, in February 2020. So I guess we need some time for this. But what I'm seeing, Mr. Bacon, in general, because I'm taking care of patients with long COVID here in Hamilton at the St. Joseph's Hospital, is that some of the symptoms may get better with time. For example, fatigue or in this difficulty breathing, some of them feel better with time. In some symptoms like the anxiety, the depression, the non-restorative sleep these people experience is not getting better, at least after 6 months from the start of their follow-up. So we see that this is an issue to these people, and this creates not only anxiety but disability. But the disability when it comes to work, some of these patients are still on short-term disability, and I'm afraid that we'll need to consider this in the future.
Now, Dr. Chung, let's follow up with this. We've been through Alpha and Delta and now Omicron. If you got long COVID under a different variant, would your symptoms and would the impact be different?
Up to now, they are very similar. Whether Omicron would be similar is still too early to tell because the definition of long COVID is having symptoms greater than 12 weeks. Our first case of Omicron in Canada was on November 22nd, 2020. So we're not even at the 3-month time point yet.
Gotcha. I want to check with all three of you and see whether all three of you, who are experts in your respective fields, whether you all agree on what causes long COVID. We heard some explanation earlier. Dr. Banerjee, what's your assessment of how do you think this happened?
I think that I would agree with Dr. Chung as far as the theories and the hypotheses. I don't think anyone really knows, but I think all those three theories are probable.
Dr. Chelios, how about you?
I will second Dr. Banerjee and Dr. Chang. The only thing I want to add, actually, is that I don't believe that there will be a single explanation on what causes long COVID. We're talking about a constellation of non-specific symptoms. I told you something about more than 200 symptoms. I think it's highly unlikely that we'll come to a single cause of this. Probably something is happening with the immune system in some patients, something is happening with the respiratory muscles, something is happening with with viral particles that persist in the body. I think that we'll come up with different definitions of long COVID, and we'll break it down to different categories that have like different underlying mechanisms.
All right, Dr. Chung, having said that, can you yet determine whether or not it affects different demographics differently? For example, maybe are there more women than men that get it, as an example?
There are definitely more women than men who get long COVID. But men get sicker and they end up in the hospital more and they have a high mortality rate. So, whether women survived it better and then they get there are higher number of women getting long COVID, but that's definitely true that we're seeing more women with long COVID.
And do you have a theory as to why it affects more women, but it affects men more strenuously?
There are many theories again. One is a sex hormone difference because women have estrogen, and there are changes in hormones over cycles in the younger in the menopause sort of with menstruation. So that's one piece. The second piece is that our immune system is different. So I like to say that every cell in our body is sexed. The behavior of the cells, it can be different. And we know we have data supporting that our immune system behaves differently between men and women.
Dr. Banerjee, can you predict who will get long COVID and who is less likely to get it?
So someone with severe symptoms, like for example, a child who's hospitalized with severe COVID and has, multi-system inflammatory syndrome, or is hospitalized with more significant symptoms, they have a higher risk of having longer symptoms. But most of the people that get long COVID, I'm talking about children, are healthy. But when you look at some of the studies, you look at some of the predisposing factors, and different studies have different findings. But type 2 diabetes, pre-existing health conditions like obesity, asthma, there seems to be a link, especially in children, being female, being older in age. So those are some of the risks. And for children, again, asthma and potentially allergies.
Dr. Chelios, can you let us in on some of the research that you're doing at McMaster University right now on this? Maybe take us behind the scenes. What's your hypothesis?
Thank you so much for the opportunity to talk about this. And I would like to acknowledge my research team. I'm working with doctors McHergy and Svenningson at the St. Joseph's Hospital here in Hamilton. What we're looking at is the involvement, the role of the immune system and autoimmunity actually in the pathogenesis of the long COVID syndrome. And we based this on our observations that in patients with more severe disease, that Dr. Banerjee commented on the severity of the initial disease, patients who were admitted in the ICU, for example, had a more excessive activation of the immune system and more autoantibodies in their blood. And patients who recovered at home did not have that much of an immune activation. And we base our hypothesis on this. What we have seen up to now is that patients with long COVID have some more activated immune system, and some of them, I won't give you a percentage because we're talking about like a small sample of 30 patients that we have said. Some of them develop full-blown autoimmune diseases, and I would like to stress this. I'm an autoimmunity expert. There have been about 50 cases worldwide with autoimmune diseases being diagnosed after COVID infection. And I think that we'll see more in the near future. We may expect like a surge in systemic autoimmune disease in the near future. So, not only in Canada, but worldwide.
Okay, let me do a quick follow-up on that. If you get long COVID then, Dr. Chelios, is it likely that you will then experience other autoimmune diseases as well?
We don't have the data to say that with confidence. What I'm saying is that some of them, if you want me to, I can give you like a 10%, close to 10%, but anyway, some of them develop systemic autoimmune disease in the form of rheumatoid arthritis, or polymyalgia or even systemic lupus erythematosus.
Dr. Chung, are there other viruses that can lead to the same kind of symptoms that people with long COVID demonstrate?
We do know that there are other viruses that can have long-term symptoms. For example, HIV is one. EBV. EBV is what is commonly known as Epstein-Barr virus or mono, can have longer-term symptoms. And there are quite a few other viruses that can, like the common one is herpes zoster. So people can get shingles from chickenpox, right? So there are many different ones. And I just want to pick up sort of what Dr. Chelios was talking about. We do know that there are other viruses like EBV, Epstein-Barr virus, that can predispose to MS, multiple sclerosis, which is a neurological autoimmune type of disease. So is it possible? Yes, it's possible. Do we know what the extent is? No, we don't. And I think it's too early to tell. But there are other precedents for this. Now, has coronavirus done this before? That's the part that we're not sure. And, you know, in the early days of this pandemic, when I asked all my virologist friends and my rheumatology friends, they often tell me that coronaviruses don't do this. So I think we're seeing something different in terms of coronaviruses.
Maybe, Dr. Banerjee, you could follow up on that in this regard. If a lot of these things, these different viruses, present in the same way, how do you know what you're fighting?
Well, right now we've got a lot of coronavirus, and so, you know, just looking at the epidemiology plus, you know, a positive test. But there are certain unique characteristics of coronavirus and COVID that you don't see in EBV, like, you know, the shortness of breath, the myocarditis, you may have funny sensations or numbness or tingling in your hands. You may have loss of taste and smell. That's pretty unique to COVID. I mean, so it's hard to tell if someone just has general fatigue, but there's enough other symptoms, like we said, 200 symptoms, that you can say this is likely COVID. And often there's a history of exposure, but not always. So you put the pieces together, and nowadays the main virus right now is COVID.
All right, let me do this follow-up with you. Typically speaking, could you compare how long COVID-19 typically lasts in a long hauler with somebody who's suffering from Epstein-Barr virus?
So, you know, we don't really know how long it's going to last. I mean, the patients I've seen, again, 2 years. I had COVID March 16th. I didn't realize it until about 3-4 weeks later, and I can't smell, and I have chills in the middle of nowhere about 3 times a week, and I start shaking. So technically, I would be called, you know, long hauler, and I've had it for 2 years now. How long will COVID last? You know, I don't know. But a lot of the long hauler patients I've seen, I'd say half of the ones I eventually discharge. That most of them are not back to baseline, but a lot of them have improved enough to be functional. So, but the symptoms with EBV, again, it can last for a very long time, and it's more vague. But COVID is much more unique in the symptoms.
I just want to make sure I heard you properly there. You've been fighting, you've had COVID symptoms, you've been fighting COVID for 2 years?
I have some, it's not interfering with my work, but I have technically long hauler because of the thermoregulation. It could be 35 degrees out and I'll be shaking with goosebumps. And that happens about 3 times a week since COVID. So yes, I can work, I'm functional, and I don't even call myself a long hauler, but I do have symptoms, and it's occupational exposure. I work in tropical medicine. I saw someone off a cruise ship who had diarrhea at the first week of March, and there you go. We didn't know much about COVID at that time.
And are you doing anything in terms of medication to treat the symptoms that you've got?
No, it doesn't really interfere with my life.
Okay, well, that's 2 of us then who've had COVID-19. I guess I should ask the other 2. Dr. Chung, have you had it?
Not that I know of.
Not that you know of, okay. Because you may have had it and be asymptomatic and it didn't affect you, so on you go. Is that it?
I too had a viral illness. I work in this area, right? So, but it was PCR negative, so it's unclear.
So you had something, but you don't know that it was COVID-19.
Mm-hmm.
Got it. Okay, Dr. Chelios, how about you?
No, I didn't have anything for the moment. All my tests have been negative. I'm triple vaccinated. I hope when I contract the virus, because I believe that all of us will contract the virus at some point. I hope that this will be mild and they won't have any long persisting symptoms.
Now, Dr. Chelios, let me stay with you on this. I know some people who've got long COVID, and in their case, it's pretty debilitating. Constant headaches and really feeling miserable and not themselves going on many months now. Can you give any advice as to how those people might want to do something?
I'm seeing the same, Mr. Pekin, and I have to admit that we don't have any specific treatment since we don't know what exactly causes this long COVID. I'm seeing patients who, as I said, are on short-term disability or a leave of absence, and they are planning to ask for long-term disability because they just can't return to work. Now, what we advise in these patients actually, and what has been shown to help a bit, is conservative management with exercise and plenty of rest, a balanced diet, and all those things that will help you feel better. From the therapeutic perspective, we don't have treatments. We prescribe symptomatic treatments for the control of pain or to help them sleep better. But no, we don't have any specific targeted treatments for long COVID yet.
Dr. Chung, can I get your advice on that? What should these people do if they have it?
We advise patients to rest and pace themselves because that works. And when they are, so I tell patients that think of you have a pot of energy, and whether you are exerting your energy physically, cognitively, or emotionally, it's still the same pot. And so when you feel like a crash or really fatigued, you should really look back at the last few days to see what you have done. It's not just that day. And so then you learn where your threshold is and you stay under that threshold. So that's one thing that we teach patients. The second thing that we teach patients is doing breathing exercises. Slow, deep breath in, and slow, deep breath kind of slowly let it out. At the top of inhalation, you take a little bit more to expand. And when you breathe all the way out, you try to squeeze the last piece out at the end. And these breathing exercises not only strengthen your breathing muscles, but also can regulate sort of your autonomic system. And so those two things we do teach patients, and depending on what their symptoms are, we do sort of prescribe medications. So, if they are coughing and we would prescribe steroid inhalers. If they are having headaches, we can give certain medications like gabapentin. So there are symptomatic treatments, as Dr. Chelios said.
Dr. Banerjee, I'm tempted right now just to take a moment and have us do those deep breathing exercises together, just in case it might be helpful. Oh, no, actually, we don't have enough time left to do that. So let's in our remaining moments here, let's focus on we understand what this is doing to individuals. I'd like a better understanding. Dr. Chelios, perhaps to you first on this. What's this doing to our healthcare system in general in terms of its ability to do what it does?
I think, Mr. Pekin, that long COVID will have a significant impact on the healthcare system in the very near future, or it already has an impact. We are estimating now more than 100,000 people in Canada with long COVID, and most of them at some point will need to have like a visit in the long COVID clinics and see what's happening. And I have the impression that these people are mostly middle-aged or young people. They are mostly women. They are mostly active professionally, and I think from what I'm saying, like 10 to 20% of these people will go on to long-term disability, and this will have like a huge impact on workforce and other expenses. And I don't even want to think about the burnout of the physicians in the long COVID clinics and in the COVID wards here in the hospitals, right? And I think that we have measures to protect our people, and like the vaccines, I think it's hugely important. I think we need to focus on that to avoid long COVID cases, to prevent these numbers.
Dr. Banerjee, is Ontario's healthcare system able to handle the requirements of treating 100,000 patients with long-term COVID?
I don't think so. Right now, we're on the cusp as it is. And I think that we're just seeing the tip of the iceberg. There's a lot of people that have symptoms that haven't yet been diagnosed or don't know that there actually is a long haul clinics. And so once those people start coming, because they have multiple health issues, the brain fog, they have neurological symptoms, cardiac symptoms, they have rapid heart rate, POTS syndrome, shortness of breath, so respiratory symptoms, joint symptoms. And again, it may be masking autoimmune disease. So there's going to be a lot of people in the next little while that are going to start surfacing with some conditions. And it may take a while to connect them back to COVID, especially if they didn't do a test or the test was negative, in fact, when they did have COVID. So I think that's going to be another major, it's going to have more impact on the healthcare system moving forward.
And Dr. Chung, just finally, is it obvious to say that if you are vaccinated, you're going to have less chance of becoming a long-haul recipient of COVID-19?
That's correct. And there are a couple of studies right now showing that if you get vaccinated, you have less severe symptoms and less long-haul symptoms.
Okay, good to know. I want to thank the three of you very much for coming on to TVO tonight and helping us out with this. This has been most instructive from right to left. Dr. Konstantin Chelios, Dr. Anna Banerjee, Dr. Angela Chung. All good wishes to the three of you. And if I may say, Dr. Banerjee, to you in particular, I really hope you get over your symptoms soon, because we need you working at 100%.
Thank you.
Thank you very much, you three.
Thank you so much.
Thank you.
Thank you.
More than 40% of doctors in Ontario are female. But according to new research, they don't occupy that same proportion of leadership roles, nor is there pay equity between male and female physicians. With us for more, we're joined from Cape Cod, Massachusetts by Sarah Kaplan. She's director of the Institute for Gender and the Economy and professor of strategic management at the Rotman School of Management at the University of Toronto. And back here in the provincial capital at Sunnybrook Hospital, Dr. Fahima Dosa, general surgery resident at the University of Toronto, and in the West End of the provincial capital, Robin Doolittle, investigative reporter with the Globe and Mail. And it's great to have you three on our program today. Dr. Dosa, I think for the first time with you, so thank you very much for joining us. Let's just get a little of the background in place before we look at this in depth, and that is, Robin, you and your colleague Chen Wong, what brought you to this story in the first place?
Yeah, so throughout 2021, Chen and I and the Globe have been rolling out this series called The Power Gap, where we have been looking at gender inequities in various professions. We've done corporate Canada with my colleague Tavia Grant, law, academia, the public sector, and the last pillar that we wanted to look at was medicine, which is a sector, of course, that has never been so visible to so many people. And, throughout the rest of the series, we've been looking at pay specifically, but because of the complicated way that doctors are compensated, we weren't able to do that. What we did was we looked at the ratio of men and women in different leadership positions in medicine. So we took the 10 largest hospitals that had the largest budgets in Ontario. We got their latest organizational charts, and we looked at the breakdown of physicians at different points. So research jobs, department chiefs, program directors, executives, and presidents.
And I gather, even though Hamilton Health Sciences would be in the top 10, they are not included in this analysis. Do you want to give us sort of the very fast reason why?
In Hamilton, I mean, we went to the government body that has tracks data on this and budgets, and they sent us the 10 largest hospital corporations by budget in the province. So we just used their list.
Okay, let's look at some.
We would have loved to do everybody, but it wasn't possible because we had to manually research each of these hundreds of data points, which is a big part of what we've been trying to expose with this series, is that we shouldn't have to do that. This information should be out there.
For sure. Okay, let's take a look at, Sheldon, if you wouldn't mind, let's bring this graphic up and we'll go through this. And for those listening on podcast, I'll just go into this in some depth here so everybody can see what's what. 67% of hospital corporation presidents in the province of Ontario are men. 33% are women. Women occupied 54% of positions at the executive level and 32% of department chiefs, 29% of division heads, and 23% of research institute leadership are women. That's a long way from 50-50, as I don't have to tell anybody because my math is bad, but it's not that bad. Robin, what would you argue, though, to somebody who might say, no, it's not 50-50, but it's not horrible either?
I mean, I think it is pretty bad. The executive level is really interesting because in that category, you can see that there actually are more women. There's 54%. What is key is at the executive level, many of those people, perhaps most, are not physicians. They're put in that role because of experience in the business sector or other areas of expertise. In the medical leadership pipeline, with department chiefs and division heads, women make up less than a third of leadership roles, and in those prestigious research positions, less than a quarter. And I think what's really important to remember is that women and men have been graduating from medical school at about the same rate for 2 decades. There are going to be more women doctors in this country than men by the end of this decade. And yet women are really far behind in terms of the leadership pipeline.
Well, we have one of them here, and I'd like to know what she thinks at the beginning of what you hope, I presume, will be a long career in the medical field. What do you think, Dr. Dosa, when you see these numbers?
Yeah, I mean, I think it reflects the lived experience that I see as I go through my medical training. You know, often we hear the argument that this is just a pipeline issue and things will get better over time. But if we reflect on the specialties that are already predominantly women, we see that that's not actually what's happening. I think if we look at obstetrics and gynecology, it's a great example of that. Predominantly women are in the majority and have been for a very long time. But even within that specialty, if you look at who's occupying the leadership positions throughout the country, it's still heavily, heavily dominated by men. So I don't think it's necessarily a pipeline issue. I don't think that we can just assume that things are going to get better on their own over time.
Well, let me make this assumption. My assumption is that the people watching or listening to this suspect that you and your male counterparts earn the same. Do you?
I'd love to say that women in medicine and in surgery, which is what I practice, make the same amount as their male counterparts. Unfortunately, we have evidence that that's not the case. We've studied that specific question here in Ontario, where physicians are primarily paid on a fee-for-service basis, meaning you get paid for the procedures that you do in surgery. And it sounds like, in theory, it should be an equitable system. And unfortunately, we've shown here in Ontario, female surgeons make about 25% less than their male counterparts.
Now, how is that possible? If you're both paid the same amount for the same service, how can you be making so much less?
Yeah, obviously, if we're doing the same service, we get paid the same amount. So really, the mechanism behind this is the idea that we're not doing the same service, that for whatever reason, women are more often doing the less lucrative procedures in surgery and probably practicing that way throughout medicine, not just in surgery. Our data show that the more remunerative a procedure becomes, the fewer and fewer women you see doing that procedure. And I don't think that's a coincidence. I don't think women are choosing to do the procedures that make or provide less income. We have to believe that there is some kind of systemic bias that's driving this.
Okay, here's our systemic bias expert now, Sarah Kaplan, who we bring into the conversation. Do we assume, Sarah Kaplan, that for whatever reason, the province of Ontario and or the Ontario Medical Association, which after all negotiates these fees, do we assume that they are putting a greater importance on the procedures mostly done by men as opposed to by women? Is that what's happening?
I think that's a really interesting hypothesis, and one that it could be true that because of the historical leadership gap that Robin already pointed out, that the people who are in power, who are negotiating these rates, are negotiating rates for the procedures that they do. I think the other reason, though, really has to do much more with referrals. So, for example, in surgery, surgeons don't do procedures without being referred a patient from another doctor. And often those referrals are biased. There's plenty of research to show that, in fact, women are getting referrals for the lower remunerating procedures than men are. And so that accumulates over time, because if you're not getting the referral to do the procedure that pays more, you're not going to be able to do that procedure.
Dr. Dosa, I presume you are a member of the Ontario Medical Association now. Do you think they know about this issue that we've just identified?
Yes, I think they do. I think they've published their own research corroborating all of this, showing that there is a gender pay gap across all medical specialties in the province. And I think they do now know that some of this is rooted in referral bias. We recently did a study, our group here, showing that that was certainly driving a fair amount of the gender pay gap. So the data are out there, and now it's just a matter of trying to address them and find solutions to this issue.
Well, that's the question, isn't it? Do you think they're adequately seized of this issue to want to do something about it?
Yes, I think, in fact, the time is now. I think that all the data are out there. If there is going to be change, this is the time. And I actually think that the pandemic opens up a window of opportunity. We've seen through the pandemic a number of ways in which our healthcare system has deficiencies, and it really gives us the opportunity to try and address numerous issues, those being to provide better, more timely and equitable care for patients, but also how to restructure our healthcare system to make sure physicians are treated equitably as well.
Sarah, let's hit on one really quite fascinating finding here, which is that health outcomes and success rates of procedures, the system measures this stuff, and they measure it when these procedures are done by male as opposed to female surgeons and or doctors. What have we learned about the outcomes depending on gender?
Well, this is a very shocking new finding that's just out, that's been making the rounds amongst the surgeons around Toronto, because I've received many calls asking for advice on how to deal with this. But the research has shown that when women have an operation from a surgeon who is male, they are 15% more likely to have negative outcomes and 32% more likely to die than if their surgeon is a woman. And that difference doesn't exist for male patients. So there's no difference between a female and a male surgeon for a male patient. So this is the kind of evidence that's suggesting that, you know, these biases, the lack of access to these professions, is creating real health inequities. And we know those health inequities go much beyond even just the surgical result, especially if you look at it intersectionally. So we know, for example, Black women are much more likely to die in childbirth, that Black people's pain is much less likely to be treated. So we can think about this along multiple dimensions, and almost all the research suggests that there are these biased outcomes when you start to look at differences between in issues of gender, race, or other.
Any idea, Sarah, what explains all that?
Well, of course, that's a long story, Steve, that you and I have been engaged in over numerous different appearances. And what I would say is there are many different mechanisms, but I believe that one of the most important mechanisms that is really contributing to this inequity right now is the myth of meritocracy. This idea that somehow the women and the men who rise up to these positions of power that Robin was talking about somehow it's only a purely meritorious system, and that if women surgeons were better, they would get better referrals. Somehow that's the idea. But we know from multiple different studies across many different professions, including sciences and medicine, that meritocracy really is a myth, that we know that women have to be twice as qualified or have much more experience to be considered to have the same level of quality as a male counterpart. And plenty of research on quotas and affirmative action basically demonstrate that your quality actually goes up when you put those in place, because it forces you to look more broadly, find the talent where it resides. And the real challenge is that, you know, when you actually put in a real meritocracy through these quotas and affirmative action, the people who fall out tend to be the people who've been historically advantaged by that system, who are the white men. And so that's to counteract this system, you're going to have to deal with those imbalances that exist.
My mother always used to say, the women always have to be twice as good as the men, and fortunately, that's not that tough to do. But that's another story for another day. Robin, let me get you back in here. Can you share some of the stories from the women that you talked to for your series that might put a little more sort of facts on the ground for about this for us?
For sure. And I think that it's important to listen to those stories, because while you can crunch all the data you want and produce reports that show statistics and percentages, it's really the anecdotal stories that I think provide a lot of context. Just to return quickly to the fee for service, like this is a prime example. The bias that's happening right now is not, oh, she's a woman, we're going to pay her less. Right? It's more nuanced than that. And that's why it's so difficult to get at. So we interviewed dozens of female physicians from across the country, and they all told very similar stories, that they were from medical school pushed into specialties that pay less, that when they are in the operating room, they are given fewer opportunities to learn, to push themselves, to take risks than their male counterparts. And these things slowly compound throughout a career. It gives them less ability to take on higher paying specialties and procedures. And I think that that's what's really key. There was this one thing that I found that just told the whole story to me there, and I hope I'm not misstating this, but the fee to make an incision on a vulva is half of the fee to make an incision on a scrotum. Like, this is the kind of stuff that is built into this system. So when it comes to the actual experiences of female physicians, what I heard a lot was that there is just this very entrenched bias in society where people view men as doctors and women as nurses. And I heard many stories of female physicians sitting down with patients and, doing a consultation, and the patient at the end going, so when is my doctor coming? When is my doctor coming in? Or patients getting a referral for a female surgeon and going back and saying, I don't want a woman to do this. Like, this is the kind of stuff that we're all battling against and trying to rewire society, because, this stuff is ingrained from a very young age.
Robin, having said that, during COVID, I can't recall a time when I've interviewed more male nurses and female doctors than over the past year and a half, 2 years. And yet you think this image of the healthcare system persists, where the man is the doctor and the woman is the nurse?
I do. And actually, I would, I haven't, done a tally of your guests, but I can say, as someone who does watch the media a lot, that actually I think there has been a disproportionate number of doctors and experts speaking on COVID that are men than women, when some of the predominant experts in this field are women. And I think that's actually a great example of where you've really seen this. And certainly through my reporting, not just in the Power Gap series, but I've done a lot of reporting on COVID as well. Those women experts are discussing this, actually. Like, this is, if they're watching right now, they're probably going,
Well, I'm going to try not to sound defensive when I ask this next question, but the fact is,
Go ahead.
we care about this and we track this stuff pretty carefully. And I know we routinely are 50-50 male-female when it comes to guests on this program. And I think it's the highest percentage of female guests of any program in North America, any current affairs program in North America, because we've made the commitment to do that. And so
let's talk about that for a second.
Sure.
Because that works then. Ratios, counting, that's what has to happen here. When we talk about how do we make improvements in this area, TVO has got it together and is making a count of this and is checking. And I think that that's something that not just in medicine, but employers across the board have to start doing. You have to start counting this stuff. And that's what the Power Gap series has been trying to do, is actually put numbers to these positions, so that the number of medical chiefs in hospitals is 32% women. The number of department heads is something like 28% women or 29% women. If you don't count it, you're not going to get better. So kudos to TVO for counting.
No, I'm not looking for kudos, but I just...
No, I'm giving you kudos.
Okay. But I do want to take that example that you just put on the record, and I want to go to Sarah on this, which is to say that if the people who are running Ontario medical schools, or if the people who are running the hospitals, or if the heads of surgeries were more often women than men, do you suspect there would be a difference in the kind of shunting of women doctors into fields that traditionally pay them less? Is there any reason to believe that would happen?
Well, there's some reason to believe that that would happen just because there may be a level of awareness. But I think it has to be more than that, because if you put women into positions of power in a traditionally patriarchal system, they're going to replicate some of those existing systems. So we need to do the kinds of things that Robin is talking about, whether the leader is a woman or a man, and also to think about that even though counting is incredibly important because it leads to accountability, counting isn't enough. It's not enough to just put a woman doctor or surgeon in a particular situation if the situation is very hostile. If, for example, they don't get the opportunities that Robin was talking about to actually try out their skills. So we need to count, but we also need to think about the organizational cultures that are leading women to be sidelined from many of the higher paying areas or higher paying procedures. So it's both counting, but it's also creating that more inclusive culture.
Okay, that takes me to Dr. Dosa now. And Dr. Dosa, you have to believe me when I say I'm really not trying to get you in trouble when I ask you this question. However, as you look around the world you inhabit, I don't know if you're only exclusively at Sunnybrook or if you practice elsewhere as well, but are the people who are in positions of leadership where you work, are they mostly male? Are they mostly female? If they are mostly female, are they perpetuating this problem, or can you tell if they're changing this problem? Take that on, if you would.
Yeah, so I moved through a lot of hospitals in Toronto, and I've seen leadership at a number of places. I think I'm fortunate in general surgery in Toronto at the University of Toronto that there are several women in leadership positions. And it's important to have those role models. I think at the hospital level, there's still work to be done. But certainly, I think that the situation that we have here at the University of Toronto is not necessarily reflective of what we see across the country or even across the province. I think Toronto and the academic program here in medicine is very unique in a lot of ways, and that might be one of them. And I agree with Sarah in that, we can't just count numbers. We actually need to change the entire environment. Because what we do know is that, if women come into these positions and act stereotypically female, they're looked down upon. They're thought to be incompetent in their positions. If women come into these leadership positions and they act like men, they're also looked down upon. They're thought to be too aggressive, too bossy. And so just putting women in these academic positions or counting the number of women in leadership is not enough. I think we really need greater change than that.
Robin, let me try this with you, because I have heard this from people who've had interactions in the healthcare system. And the thesis goes something like this. Of course, women are paid less than men. If they're GPs, they work many hours fewer than men because they want to have more balanced lives than their male counterparts. They don't want to work 80 hours a week and never see their families and never be able to have interactions with their parents or their kids. And that's why they're paid less. How much truth is there in that?
I think this is such an important thing to discuss and that we've been hearing throughout doing this reporting. The goal here is not that everyone should be working 100 hours a week, or maybe it is. It's really up to the individual person, right? And I think that sometimes we conflate these conversations as, oh, if only women definitely worked more, this would be solved. And maybe men don't want to work as much either, right? Like this is kind of a shift that's happening with COVID as people are reevaluating what they want in life. I think the big thing is, what's the preference, right? Like if someone wants to work part-time, that's great. If they want to work 100 hours a week, that's great. We know that women are being pushed into these lower paying specialties, are making less money, are securing less lucrative positions and leadership positions, not just because they gosh darn don't want to work that much, right? And that's really what this is about. So there is certainly a huge number of people, I think, that's say what you were saying. I think what was really interesting to me doing this research, Dr. Dosa is like the premier researcher on this right now. And part of what we told in those stories was the pushback that she and her colleagues received in trying to even get this research published in medical journals, because some of the reviewers were writing back, well, probably women are working less because they're getting paid less because they don't want to work as much, which is no place in a review for a scientific journal. Like, the defensiveness that people have when they say that, I think is just an example of how hard it is to overcome this.
Dr. Dosa, you want to talk about that pushback for a moment?
Sure. I think there are a few notes coming back to your last point that are important to make. The first one being that there are actually more men in medicine who have families than there are women. So part of fixing this issue is also coming to terms with should have the opportunity to play a role in their families as well. And that this shouldn't only be looked at as the role of women in medicine. Coming back to that idea that women make less because they work less, we actually tried to address that specific issue in our work. And what we looked at was how much women were making for the time they spent working, to take out this idea that women just make less because they work less. And we looked at how much they were making for every hour they spent operating. And even then, they make less money than do men. And as Robin said, this work was very, very challenging to get published, as have our subsequent projects related to this issue. And, I think people want to believe that they're not biased and that the systems that they work in are unbiased and that they got to where they are through a completely meritocratic system. And so it's easy to get defensive, and it's easy to look for reasons why these data can't be true. But we've looked at it a million ways. We're not the only ones to show these results. And I think we show time and time again that this is an issue, and we're all estimating the same magnitude of the issue. And so it's hard not to believe the data.
Okay, here's my smart aleck question now for Sarah Kaplan. And that is, the public right now has a finite number of things that they can care about because, of course, they've been dealing with COVID for 2 years, and people have had just about enough. You have all identified an issue here that is a real issue, but it's a real issue for people, most of whom are really well paid when you consider everybody else in society. Which leads to the question, Sarah, how much should people really give a damn about this?
Well, I think they should care a lot, because what it means to not have women's voice represented or the voices of people of color represented in medicine means that, first of all, the outcomes that we talked about, women and people of color, which is now, the vast majority of people in our society are actually not getting the level of care they should be getting simply because of the biases that have been built into the system, so that they don't have the people caring for them who can really understand and their issues and treat them with respect. So everyone should care, because the health system is worse for it and their outcomes are worse for it. And I think people should also care because medicine is kind of a flag bearer for a lot of other industries. And this is a story that plays out in literally every industry that I have ever studied. This exact issue plays out. It's the same with boards of directors. And if you don't have those people in positions of power, which has been what's so powerful about Robin's reporting, you don't get decisions that fairly consider everyone in society. So I think we should all be pretty seriously worried about these findings that Dr. Dosa and that Robin have put forward.
Robin, can I get you on that as well? I mean, even the women in the healthcare system who are doctors, who feel the least powerful, they're still making six-figure salaries. So, okay, hit me with your best shot.
I mean, you should get paid what you earn. That's just or what you deserve. That's like some pretty basic stuff. I think I've certainly heard that. Particularly, we were doing our in our legal analysis, looking at law firms, and women were equity partners were making 25% of what their male counterparts were making. And in that case, we actually had dollar amounts, and it was north of $300,000 difference. And people are saying, "Who cares?" When you think of women who are in the top of their field, in professions that are the most respected by society, or among the most respected in society, and they can't do it. They can't get equity. They can't get an equal voice. That's really concerning. And You mentioned it off the top when you were talking to Sarah that, there's so much stuff going on right now. Can we focus on this? I'm not going to lie. When we were rolling out this series, that was something that really weighed on our minds, and particularly my mind, that what's the right time to ask people to care about gender equity in the workforce when there is no workforce. This was the beginning of COVID. And ultimately, we thought, actually, this is the perfect time because we are reevaluating everything about how we live right now. We are reevaluating our relationship with work and and the role that work plays in our lives. And when we build back, this is the moment that we can address so many of these things because we're going to have to overhaul everything anyway.
In our last 30 seconds, Dr. Dosa, this is all part of Build Back Better for you. Is that right?
Well, I think so. And I want to move away from the idea of this being only about money. And I think importantly, there is a piece here to create better care for patients. If we're constantly sending patients to the white male physician, there's probably a whole host of other physicians who can see the patient more quickly and, as data would show, may even provide better care for that patient. So I think we need to move away from the idea of long wait times for physicians who simply harbor our mental image of what a physician should look like.
Robin Doolittle, Dr. Fahima Dosa, Sarah Kaplan. Good of all three of you to spend so much time with us on TVO tonight. Many thanks.
Thank you.
And that is the agenda for Monday, January 31st, 2022. Tomorrow, a conversation with documentary filmmaker Jennifer Holness, ahead of the broadcast premiere on TVO of her documentary, Subjects of Desire, that explores how conventional ideas of beauty often excluded Black women and girls. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.